Okay, welcome all to this episode of your Freedom Hub's Free Market Cash Patient. I'm your host, Jeff Cantor, along with Charles Froman. We are definitely sponsored by the Marketplace for Health, Wealth, and Freedom, and we encourage you to go check it out. We'll definitely do a little detour through there. We are the Disruptors intersection, and it's a pretty important place to be, and so we're glad that you're here. And in the health world, we've definitely got a problem. And most people have finally figured out what it is. We could also add government and some other stuff to that center, but it's definitely everything in between you and your doc. And information is very mixed as far as what everyone's getting to hear. So you can't even figure out which end is up half the time. And we also try to cover some other areas. So we have another event and we want you to be aware of that. So these are some links to see videos over there. And as I said, this is the main site where you can access all of these things. And there's 2 domain names that get you to the same place. And at the bottom, we're giving you one if you want to learn more about doing something for your health, as it were, and want to maybe escape from insurance. You can reference that particular web domain. But in the meantime, let's take a quick gander at the site. So when you're coming to the home page, you'll see there's an awful lot of interesting areas. The marketplace is really quite interesting for sure. And then we have under the home tab, there's the webinars page and the continuing the conversation. This in many ways is the most important because after we get excited about what we hear today, we want to follow up with that person. So we click on that and end up on this particular page where you'll be able to connect with all these different guests that we've had. And just to give you a flavor, when we're on this page, if you scroll down a ways, here's the people we are going to have on it, which will come back, who's coming up. And then here at the bottom, the links to where these are all reside come Monday. So on both sides of the aisle, here's what we've got. As an example, this is the one that represents the event right now. This is the one from the 4 o'clock. So you'll see there's an awful lot. And in both instances, you can connect with the guests. Also, when you're under the Freedom tab, you'll see Fighting for Freedom. Here's another important area to be very aware of. We're curating all the key issues and action items for you to kind of deal with that have to do with your health. And then a lot of organizations that are working on freedom for your behalf. So it's a pretty interesting area here to come back and explore. But let's dig into today. So when we come back up here, we are at our 7 o'clock Community Healthcare for Biz Owners in Real America. So Charles is going to do the introduction here, and then we're going to have our guests take over.
Gladly, Jeff, and welcome, Bob. I guess I met Bob a few years ago on LinkedIn as Jeff and I were networking through that social media platform to advertise what became the Forbes featured combo of sharing and HSAs to help patients shop on price and quality. And in learning about Bob, we discovered he was one of those Rosetta type brokers that Jeff and I identify, since we're not really in that market and Bob is, as those smarter advisors that help the bigger employers save money, which is really hard to do with insurance. And they do kick out insurance. We've had previous speakers like Nelson Griswold and Carl Schuessler by direct contracting between the employer and independent doctors and facilities in the local region. And Bob is going to present his version of that, which he calls sort of a community care solution. And to me, it sort of lifts all the boats in the local area, which to me is so important for, a topic that I've dealt with working in Congress or as a lobbyist, and that's underserved access in rural areas. But this works really anywhere, urban or rural. It just so happens that, Bob has a community aspect to it that is interesting. Recently we had a community pharmacist present. We've had direct primary care. We've had independent surgeons. Bob is the advisor who brings all those folks together for the bigger employers. And that is our intro, Jeff.
All right, very good. Well, on that note, Bob, I'm going to relinquish the screen, and now you are in control.
Well, first of all, thank you, gentlemen, for having me, and I appreciate the very kind introduction. it's a passion of mine to try to help fix this particular challenge. And this, what I'm going to go through today, really started about 4 or 5 years ago with a architect and engineer who was a client of mine, actually. And we, we're talking back and forth about how do we address the issues. He's a very small employer, about 15 employees at the time. Now I think he has 25. But we flipped him from fully insured to a level funded plan and saved him a bunch of money. And he actually ended up going cost share and was cash pay. He has just had his 11th child, literally last week. So he is prolific in that particular area. But he is a terrific guy, and he is a disabled vet and former military, obviously. And so we've been working on this for 4 or 5 years. And what we recognized was employers were frustrated beyond belief with healthcare. Patients have no idea what they're doing. It's impossible to find or shop for healthcare 5 years ago. It's better today, but it's still difficult if you don't have somebody helping you. And at the same time, you had providers and hospitals and physicians who were looking to get away from the healthcare systems and the production model that they've become. And so the biggest challenge for the providers is, how do I leave the comfort of the salary I'm getting from the big healthcare system and jump into the pool and try to do this independently without a group of patients for which to do that with. And the same thing on the other side, you have employers who are starving to try to solve the problem of their healthcare costs because it's either number 2 or number 3 on their profit and loss statement. And so what we really kind of created, and you'll see that hopefully, is we've kind of created eHarmony for healthcare, for employers and providers to come together. Specifically, most of the work is being done in the state of Wisconsin today, but I do live in Fort Myers, Florida. I'm doing some work down here as well, and we have opportunities in Memphis and in Wichita. And I hope if this is appealing to some of those around the country, we can help develop it in your community as well. So I'm going to walk through some information regarding how we got there, and then really specifically around the design of the clinic itself. So we needed a partnership-driven solution. So again, this has taken 5 years to get to this, but the jumble on the left is what it looks like to a patient or an employee trying to get their health needs taken care of. And what we're trying to create is, over on the right, is an ecosystem, a cohesive ecosystem for them to be able to easily access healthcare, be compliant with their healthcare, and more importantly, for the employer, you don't want employees running around who aren't being compliant with their care, taking their medication. It's too expensive, so I'm just not going to do it. Those are landmines for self-insured plans that we're really trying to help avoid for the employer. Where did that go? Oh, yeah. Why is that not? Huh. I can't get the slides to go. Hang on.
Sometimes you have to just click on the screen to kind of activate it, and then it'll start to go.
There we go. So again, these are probably slides that some of you have seen, but I wanted to walk through them again real quick. This is really since 2000 to 2018 or so. You can see the overall cost of healthcare has been 4 times faster than wages, and family premiums obviously going up, and the contributions that the employees have to make. What we got to was the point where it was just unsustainable to continue to raise deductibles for families and of the employees. And we have a bunch of people running around who are literally functionally uninsured. So they have a card, they can access healthcare if they want to, but they literally can't afford to do it, or they don't know how to do it in an affordable way. I think that's probably a better way of saying it. And so we need to educate them and get them engaged in the process in order to help them come along with us on this journey. This is another slide that really illustrates over the last 20 years the cost of hospital services, college tuition, textbooks. All of those things are running significantly more expensive than new cars, clothing, cell phones, computers, toys, and TV. And the reason for that is all the ones on the bottom are competitive. Those are all competitive markets where the ones on the top really are not. And so absent competition, the healthcare systems continue to take advantage of employers and the communities that they work. And this may sound like I'm beating up on the healthcare systems in general. I'm really not. They're pretty good partners with us as well. It's just that the way they've done business in the past 20, 30 years has really become unsustainable for the employers. This is one of the other reasons, if you look over 30 or 40 years, the number of physicians in the country really hasn't changed all that much. But you can look at the middle management and the layers of waste in the middle there with administration over the years. That adds to the cost of healthcare. Literally half or just a little bit more than half of every dollar that's spent on healthcare actually goes for healthcare. The rest is for administration and folks in the middle. And then these were just some articles that illustrated that fact. The real sad part for primary care, which really is the driver of all this, is the number of primary care physicians who are committing suicide every year is astounding. And it's because they get out of medical school, they think they're going to go practice and do what they dreamed of doing and had a passion to do, and they end up being 8 hours a day on their computer typing in information on an electronic medical record and not caring for patients. We're trying to give them a place where they can do that again. So the disruptive model really, and I date myself when I say this, kind of begins and ends with primary care, and I call it the Dr. Welby Strategy. So for those of you who aren't old enough to know who Dr. Welby was, he was a TB doctor back in the 60s. But what he was the family doctor. And we need to get back to a point in healthcare where we have individuals and family members who have a relationship with their physician, much like they have a relationship with their accountant or their attorney or their other trusted advisors, so that somebody is keeping an eye on literally what is the most important thing to them, which is their health. Without your health, none of that other stuff really matters. So we want to keep people healthy, avoid chronic diseases, which drive cost for both the patient and for the employer. So it really kind of begins, we need to get people engaged. The only way to do that is to really have a more robust primary care offering that is available to many of them in the community today. That means DPC, that means on-site or near-site clinic providers who can actually spend time with the patient, as opposed to the standard 5 to 8 minutes you get with a physician in the hospital systems today. That's just no way to keep people healthy. And then as soon as we have the patient engaged, we can then go around the circle here. We can do care navigation. We can work on the RX plan. We can do all these things, all the innovative things that are out there today, but without the patient being engaged first, we have no hope at all of making any change. So we need two things. We need the patient to be engaged, and we need the employer, typically, hopefully from the CEO on down, driving this engagement as a core strategy for the employer if they really want to make a difference in their healthcare costs. So some of you know I live in Fort Myers, Florida today, but I also work in the state of Wisconsin, where I just moved from last fall. I was in the Milwaukee area. So I'm working both the Wisconsin market and the Florida market, but you're going to see from this model, we actually have opportunities in other parts of the country as well. And what it is typically is we have 1 to 500 life employers who are just not quite big enough to really do their own on-site clinic, but like the idea and want to somehow participate in that idea, but they don't know 2 or 3 other employers that they can join forces with. And that's where kind of the eHarmony thing comes in for us, is we're trying to work with the local chambers of commerce and economic development councils to really try to drive information into the marketplace, the town halls and the like, to try to get these employers together, to band together, to really attack the problem. And when we do that, the on-site clinics are terrific and they can do really, really good work. They do have a few downfalls. One is spouses and children not necessarily all that interested in going to the place of business to get healthcare. In a lot of cases, they prefer to go somewhere else. So a near-site alternative to that can be an attractive one to try to drive what literally is, for most plans, at minimum half of their spend goes on spouses and dependents. So we can't just attack half the problem. We have to attack all the problem and give them all the solutions they need to make the right choices for value-based care. So by putting these 3, 4, 5 employer groups together, we need about 1,500 belly buttons. That does 2 things. It excites the providers, right? Now I have enough patients where I can step out of the system, or maybe they're already a DPC and but they want to drive more patients into their practice. This is a way we can help them drive more patients into the building. And then the other component of that is we need to get the employers together to have enough mass to create one of these facilities that we're going to talk about today. And we intend to do it all over the country. So And here's what's possible. When we get the patient engaged, we get them in a really good primary care setting, and we deploy all of the strategies that we can bring to bear. And many of you, I'm sure, are doing those today, carving out the PBM, all sorts of things that are very creative and thoughtful about how to drive down costs for the employer. We want to make sure we're doing it for the employee as well. What this chart shows you, this is literally half of the savings that we had for a school system up in northern Wisconsin. It's just run out over 20 or over 10 years to show what's possible for this particular community if they were to join forces. So we've just extrapolated. It was a 37% drop in healthcare costs by putting in a clinic, negotiating direct contracts. We did some direct contract with systems and with specialty providers. So it wasn't just one or the other, it was really both. And then in addition to that, we partnered with a couple of other groups to bring some other cost savings to the group, but it was 37% over 2 years. We saved that school system on their health plan. What this chart illustrates is half of that savings, to be a little more conservative. It's pretty high cost area of the state, so we want to be fair. But what this shows you on the blue line is a 10% trend on healthcare costs. The orange is a 5% trend. A lot of employers are kind of stuck in that mix right in there, a little closer to 5 today for most. But what the green line represents is what we did for that group. And that is we reduced their health costs. And over time, since these are all direct contracts, or most of them are, it'll be inflationary growth. It won't be attributed to some wild healthcare system. Independent physicians don't need to charge 6% bumps a year when inflation is 2%. And so we help them negotiate those contracts to make sure that they're long-term and lasting. What this illustrates is, for this is actually a 1,500 life. We've taken it and expanded it to a full clinic. And this particular clinic in this facility would save over 10 years, somewhere between 30 and $40 million would be saved, which would be in the community then, not being shipped off to one of the BUCAs or to a big healthcare system somewhere in the country that's some monolith. So all those dollars would stay in the community for the community to use for their needs, be it groceries or the cleaners or restaurants in town, movie theaters. So we want to keep the economic impact in town. So what we've designed, and it's really modular, there are 3 different or 4 different phases to a particular building that we're helping establish in one of these communities. The gray area you see kind of on the top there is really the first phase, which is 3 suites. And this is about 10,000 square feet. Each suite is around 3,000. And then in the back of the building, we're putting in a mobile imaging dock so that we can have the mobile imaging truck pull right up to the building. People can schedule their scans and get them done for $300 to $500 as opposed to $3,500 at the healthcare system. So we want to make it convenient and easy for people to be compliant. So you have primary care clinic, which is the driver. Right next to that, a physical therapy clinic. Many of these communities we're working in are old, rural-ish communities just outside of the major metropolitan areas. And a lot of old manufacturing. So musculoskeletal issues for these employers is very, very important to address, both on the medical and the work comp side. So we think having a physical therapy group right next door where they can partner with primary care to really treat the whole patient. So maybe we can fix it with physical therapy first rather than going right to the orthopedic and getting a surgery scheduled. We can help save money on the surgery as well, but the best surgery is the one avoided. So, and then the last component of that initial phase of the building is a specialty suite, which would be kind of a rotating list of specialists. So think cardiology, orthopedics, podiatry, mental health, which is an enormous one today. But in a lot of these communities, you don't need an orthopedic there 5 days a week. 1 day, maybe a day and a half a week is really sufficient. You can allow the patient to do their pre and post work close to home, so they're not traveling for that. It's more productive for the employer that they're not traveling 60 to 90 minutes to go get care. Kind of takes up a whole day just to go get an analysis done. They can actually have it done in the building right in town. And then wellness and education would be part of that as well. And then you can see what we're looking to add to some of these as we go forward. We think dental is a very important one to have attached to this. Your oral health is a direct link to your overall health. So to provide dental, independent urgent care, not tied to any healthcare system. Short stay observation unit is really a 23-hour hospital. with an ambulatory surgery center. And then maybe if we have enough imaging, maybe do a full service imaging facility on site with also labs. So you can kind of see the idea here is to start with the three main components and then build the building out as we really determine what the needs of that community are, and then work towards getting the right providers to join that group. All of them transparent, all of them independent, and all of them willing to do direct contracts with the employers and their families. Interestingly, the only one that's really membership driven or kind of a capitated model is the primary care. All of the other services are available to the community at large. It's just the primary care that's being driven by the employers, which is really a membership or subscription based, whether that be DPT, traditional DPT, or an on-site near-site clinic provider. And so as we build these buildings out, it's designed to be a collaborative space. So we want exam rooms to feed to a common area where physicians and physical therapists and specialists can kind of work together in a collaborative way to really address the patient's needs. So it's all patient-centric, obviously aided with technology to help us get to that ecosystem that we're looking to get, which is how many of these services can we provide for this employee and their families in this facility where we have a known cost for the employer, and that known cost is substantially less than if they end up in the healthcare system. And if you want to look at it from a pure design standpoint, this is kind of what the buildings look like or are intended to look like. They're all one-story wood frame construction to keep costs down. So you kind of see that on the left, and then the picture on the right really is kind of what the inside of the buildings are going to look like. So it looks nice. It's a nice looking medical facility. It's not going to the manufacturing plant for the spouse and the kids to get their health care, or, you know, worse, I know there's communities that the city has a on-site clinic, but it's literally in the maintenance shed for the transportation. So they're pulling in where all the trucks are coming out, the salt and the sand and the plows. That's not really convenient or really an appropriate place to seek care for family members. So this is designed to look, feel like a medical facility, but with costs being as low as we can keep them in mind. The other thing that we're doing, which is hopefully interesting, maybe not the best business model long-term for Greg and I, this is not intended to be a franchise effort. This is, Agile is trademarked just to be a brand name, which gives us some power as we have more patients in a particular area to negotiate with the healthcare systems. But each one of these facilities will be independently owned and operated, and the employers are the first ones that get the opportunity to be the investor in the building. If they choose to invest and they want to invest the entire amount, own the building themselves, and then they can pick and choose how the providers come in and out of there. It's really up to them to drive their healthcare ecosystem then. In the absence of that, we have other investors who will help provide the capital necessary to fund the buildings, which will allow these employers to make that investment in their employees through primary care and all these other strategies which can help reduce cost. We also want to use local bank financing if we can. So we use a local financial institution to do the lending if we can. And we will use local construction companies for the actual build. We can't use, you know, Bob's Basement Remodeling, but if they're licensed and insured contractors that are capable of doing the work, we will try to use local resources. Again, the method here is all of the money that's being created from this entity is designed to stay in that particular community. And so these are really, I think Charles kind of alluded to it, but it's really underserved communities where they have limited access and it's hard to get to, and maybe they have one healthcare system, but it's also overserved communities. So there are some that right in the collar counties of Milwaukee area where they basically have two healthcare systems, which are really taking advantage of a lot of the employers in that community. So I would consider those overserved. So if we can provide a better mousetrap for them to capture and be transparent and have cash pay as much as possible on these costs directly with providers, we can help them as well. And then this really just kind of shows you the platform where this is actually one in Waterford, Wisconsin that we're contemplating. We want to make sure that we have 4 to 6 acres so that we can expand the footprint of the building as the needs of that community change. So even though we're starting somewhat small, we want to make sure we can grow it out and add more services as we go forward. And then really the process starts with, there's really four ways that we get interest in a community. It can be employer driven, which we've had in communities in Wisconsin where four employers got together and decided we want to do this and let's band together. It can be broker consultant driven. If we have a broker or consultant has a number of firms right in the same area that they can help us put that together, great. Provider driven, certainly. We have some physical therapy groups who are trying to help put these up. And obviously the specialty providers. And then the last one really is us, is Greg and Bob and people that we know trying to help deliver the message across the country that we think this is a pretty good way to do it. And the results have been fantastic in the employers that we kind of put all these together. Now we're just trying to put them all in one building. So the value prop is that we got to get the employers together, get the site, the program management, the due diligence, all that real estate stuff has to happen. And then we manage phase 2 of that project through IT integration and the project development until we get to phase 3, which is procurement, rollout, delivery, construction management, get the building up, put a shovel in the ground, get it open in 8 to 9 months from the time that we have the go ahead from the employers or the community at large to go forward with the project. So we can get these up pretty quick. It's really beneficial for self-funded employers because there's a direct savings. Fully insured groups can still participate, and we have some that are doing that. They're doing it because they're leaning towards going self-funded, and they're looking at this as kind of a baby step. And we're trying to work with the health carrier to take into account the money that they're spending on the primary care at a minimum to address that. So I think with that, Charles and Jeff, I think that is it for me.
Okay.
Open to any questions.
Yes, I think we will. Hold on a moment here. Let me bring this back. Okay, let's do it. So that, one thing that's nice about what you guys have conceptualized is putting everything together in one place, because it's hard to imagine good traction when I'm like in this self-insured scenario, but everybody's all scattered all over. So, it's a consumer I lose track of what is my reality. So this is great. And then you can build synergies because you got a place to point to. So that's great. What's been the receptivity of doctors? In general, like let's say it's employer driven or whatever, they're the driver and you're now looking to find a doc. How are they excited about this?
Yeah, we don't have any trouble finding either specialty providers who are interested in this model or direct primary care doctors who are exceptionally interested in this particular model. If you think about it from the provider, particularly primary care, what is the number? 600 to 700 belly buttons is the right number for a direct primary care doc to really, that's about the maximum that they can manage. So we're immediately putting somebody into a position where they have a practice and they probably need to hire somebody right away in order to help manage the patient flow. And interestingly, the first place we started this, even before we got a shovel in the ground, of the original 4 employers, we had 2 more calling us wanting to get in the building. So especially in these smaller communities, everybody talks to everybody else. So what are you doing? You're going to put them, how do we get in there? So there's some momentum around, people wanting to join the effort to reduce healthcare costs.
Plus it gives me, if I'm a doctor, a sense of security. If I'm leaving some other setup, this sounds like a really good version of what I used to have. So that's good. Charles, I see your hand is up.
It is. And Bob, excellent presentation. Very nice slides. I like very just nice, approachable design, everything. Is your innovation that different from other Rosetta type brokers trying to directly contract and build communities? And if it's not, is there a common barrier for all of your fellow advisors' efforts in that you've got the chicken and the egg issue so many of us face to get the group of employers to adopt it, the independent leaning practitioners to make the jump and make it work? Comment on that. And I like your idea about marketing through the local chambers of commerce with town halls to get the word out. That seems to be an answer to that barrier that we've faced with our cash appointments app, or getting everyone on sharing at the same time. Anyways, any thoughts on that overall?
Yeah, so the biggest challenge really is the biggest one. It's kind of like herding cats to get employers together, and there's a couple of reasons for that. One, they all do something different. They all have different cultures, and in many cases, they all have different brokers or consultants or advisors. So, the broker community sometimes may look at us as being a competitor. We're not, and we're literally just trying to give them the tools necessary to help their employer groups and their family members drive down healthcare costs. Other advisors certainly do all of the component parts of what we talked about doing, which is, the primary care, the direct contracting, the fix the RX, all that stuff. Sequentially, there's a sequential way you do that, at least in my opinion, that all starts with patient engagement and care navigation and that kind of stuff. But what they're missing is, I think, respectfully, is we're sending them to all sorts of places around the community, or in some cases around the country, to get care because it's good and it's inexpensive, and they're willing to pay for that to do that. But if I can get surgery done in Appleton, Wisconsin, as opposed to having to send them to Oklahoma City, where I know they do a good job, but it's really not convenient. We're trying to bring all of those strategies that a lot of these Health Rosetta advisors are using and putting them together in one convenient package in the community. And then that community will have one, and this community will have one, and we'll try to put them around the state. So then we get more leverage with the healthcare system when it comes time to negotiate direct contracts. We've had remarkable success getting in Wisconsin, which is a difficult state, getting some of the healthcare systems to play nice in the sandbox with us. And we need them. We need them to still be in the community and be an important cog in the wheel as well.
Very good. Paul, I see your hand up.
Yeah, nice job, Bob. Yeah, just a two-part question, actually. The first part of the question is whether or not social media gives you any lift. I know that's kind of a challenge, but or even advertising, I don't know if you do any kind of Google or Facebook advertising, anything like that. The second question would be if you could perhaps go into a little more detail as far as the pitch angle with the carriers specifically. I know that there certainly isn't as much room to work with as self-funded employers, but how much wiggle room is there with them?
Yeah, so not much wiggle room with the health carriers for a fully insured group. There are some that are willing to play and do things to help the employer. Maybe they've been a customer of theirs for a number of years, and there's a loyalty factor there that comes into play. They understand what you're doing. You're taking baby steps to try to become self-funded and make them obsolete. So they're conscious of that. So we need to be careful how we address that. But if they're spending $40, $50 per member per month to have primary care capitated, and there's not going to be claims for that anymore, there needs to be some partnership with either advisor pushing the health carrier to do that. Some health carriers just won't do it. We just try to move into a carrier who's more willing to play ball. And as far as the social media aspect, I'm sorry, what was that first question again, Paul? I'm sorry.
Yeah, no, I was just asking if you have any lift from social media, what your initiative has been as far as that. I mean, sometimes it works, sometimes it doesn't. It's kind of challenging as it is, but I was just kind of curious about that.
Well, it's been, we just literally last July had the first kind of commitment to move forward in one community. And we're already talking to somewhere between 12 and 15 different communities just in the state of Wisconsin, not to mention a few down here in Florida already, and then Memphis and Wichita, Kansas. So it took off pretty quickly without us having to do a whole lot of pushing. And frankly, it's just Greg and I. So we can help each of the consultants on the phone, try to put the pieces together in their community without having to recreate the wheel. I think that we took 4 or 5 years in thoughtful consideration to put it together this way. we're happy to share that information. Again, each of these is independently owned and operated and not a franchise or a way for Greg and Bob to, it's not some get rich quick scheme. It's how do we help the employers in this community save money?
Real quick, I want throwing in a sideball question. If you just put one of your little push pin maps up on the wall, how many places in America are there that need what you're talking about?
Oh, I think you can put a blindfold on and throw a dart. And if you hit a community that has enough manufacturing or service work that you can get 1,500 belly buttons together, I can't see why this wouldn't be a value in any community.
No, I don't mean that's it. How many communities are there in America that need this?
I don't know that answer off the top of my head, Jeff.
Thousands.
Thousands, yeah.
Charles, your hand's rolling up there.
Bob, for the outlier maverick employee who may not want to go to the on-site or near-site DPC or specialist, what is the contingency for them? I mean, direct primary care is a good value for most people, that monthly subscription. But some folks may not want to go there. Have you added that to your plan?
Yeah, we certainly have to build incentives in the plan around trying to drive or change the behavior of the employees, but we're not forcing anybody to give up their family. If they already have a relationship with a doctor, we're not trying to get them to unseat that particular relationship. If it's working, I'm not here to break it. If they're happy with their doctor and their health is good, why would you want to upset that? But what we do is we encourage the employer and their advisor to design incentives around driving the patient behavior to the things we want them to do. So, if you go outside of this particular group, it's not tier one, you're going to pay the full deductible and co-insurance. And if they're happy to do that on their own and they're fine doing it, then that's their choice. In tier one, it might be, we're going to pay for your deductible and your copay if you go get your surgery here as opposed to here. And we'll pay for your overnight stay and your meals while you're there. It's that kind of incentive that really helps drive patient behavior. On the primary care side, it's a little more tricky, but they don't not have to go to that particular, and frankly, the employer wouldn't want to pay for that employee to use that service if they're not going to.
This is a follow-up. To that extent, it's not just the family doctor with whom they have a relationship, but maybe even alternative care. That's growing hugely. Naturopaths, chiropractors, osteopathic, just integrated. What do you do for those employees? I'm not sure how many of those you would find in a manufacturing business, but someone is not meeting themselves. But have you considered that maverick type employee that may want to go outside the allopathic DPC shop?
Yeah, I just personal story. I had been taking a number of pharmaceutical medications, and I've gone that route myself. So I'm trying to treat it with all medications. Frankly, I'm paying for out of pocket right now. But I think you encourage, certainly if the employer is self-funded, they can pay for those types of things if they want to. And then if you want to go down this path, we'll pay for this much, and you just design it around how much they feel like they want to spend per employee for that type of care. In a lot of those cases, and in mine, it seems to be working very, very well. I'm pleased to be off of the pharmaceuticals I've been on.
Very nice. Dr. Campbell?
Yes, excellent presentation. It does seem like that the costs driven by these variety of middlemen, the BUCAs, and other inflationary incentives has given us an opportunity to demonstrate tremendous cost savings. Now, I'm wondering, I got two questions. One is, how many covered lives have you executed this on? And number two, what do you rank as the most important core necessary elements? I'm thinking DPC and somehow getting around the PBMs. But that's my question. What are your core elements, and how many covered lives have you executed this on?
Yeah, so to date, executed about 2,000, just under 2,000. It's the first clinic we started, but we have ongoing discussions with somewhere between 12 and 15 just in the state of Wisconsin. And I would imagine this year we'll probably get 3 or 4 of those to commit before the end of the year. And then I would imagine the following year it'll be a multiplying factor on that. So, and then the second question, I apologize. The second question, the core things are for me, first and foremost, patient engagement. Secondly, would be designing the incentives around driving the behavior for the employee and providing them care navigation so they don't have to figure it out. So I think care navigators are underutilized in a lot of communities, and we're blessed to have some in the state of Wisconsin that do a great job. And so I know that if I attach incentives around a person for this patient to call when they have a healthcare need, and that patient is getting the number for the care navigator from their direct primary care doctor and saying, you need to call this person. They're going to give you all your options that fit your plan. So you have options as to where you want to go to get your care for cardiology, orthopedics, whatever it might be. So design the incentives to match the care that you want on the other end of that. And that really is where a lot of the savings are driven. Those 3 things. PBM certainly on the back end of that. Direct contracting certainly with multiple specialty providers, not just orthopedics, can really drive down costs. And then last but not least, if you have a healthcare system in town that is willing to direct contract with you, which we've had happen in Wisconsin, you can get rid of the PPO entirely and just have one place for all of your employees to go. If they go outside of that, again, you're paying your deductible and your copays, but we're giving you an option where we as an employer are being respectful of the amount of money that we're spending and that all of the other employees in the company have to pay.
Very nice. And what's also quite good is that coordinator aspect, is almost underplaying that. But most people, they get so confused and concerned, and just gives them such a level of confidence. And then, like you said, it helps them. Boy, I do want to do the right thing, but boy, how do I do it? Well, here, let me just show you the whole thing. You just sign right here. Awesome. Where you been my whole life? So it's great. Charles, I see your hand up.
Bob, is it exclusively self-funding that you're using to pay for this arrangement with the near-site clinic, or as competition brings new options for these employers, for example, not just sharing, but with Trump's ICRA, the individual coverage health reimbursement arrangement, that's going to allow larger and larger employers to say, the heck with the employer model. I'm just giving money to my employees. You go buy probably a sharing arrangement, the cheapest, best, or an ACA plan. Has your model incorporated the payment side, or right now is self-funding pretty much all you need at this moment in your timeline?
Well, if you think about a community like, the town is Clintonville, by the way, the first one. It's a small community, but they have a number of employers in that 1 to 500 range. And so the what we call larger employers in those communities, 1 to 500, are kind of the catalysts for getting the facility created. But what it allows is exactly what you're talking about, Charles. It allows the 20-person employer and the 15-person employer, maybe the barber shop or the beauty salon or the restaurant owner or the bar owner who wants to take care of his employees, to do exactly what you just described. But we need to get the facility there first, right? It's driven by the self-funded employers in many cases, or maybe even some of the providers driving that. But the intention is get that catalyst from the larger employers, and then we can kind of go downstream and employ all of the strategies that you talk about. As you know, I'm a cost share guy myself, and I'm saving probably 20 grand a year by doing that. So I just think it's a terrific model, and it is something we can share with them. But it's kind of stage one, get the building up and funded with the employers in town, and then work downstream to take care of the other employers.
Very nice. Any other questions here? I'm looking for some hands up. Or if you can't figure out how to do that, you can unmute yourself at this point and ask.
I'll blurt out, Bob. You mentioned Wisconsin, and Florida, but you also hinted at other parts of the country. Do you have your eyes set on any particular other areas of the country at this point?
No, we just happen to have an opportunity in Memphis and one in the Wichita, Kansas area that we're exploring at the moment. we're open to helping share this information with anybody who's interested to try to help create one of these facilities in your local community with you. If it happens to be your clients, if you're the broker advisor, great. If you're the employer and you want to help, you need help trying to herd the cats and get other employers involved, we'll work with economic development councils in the chambers to try to get enough mass in order to create that for you.
Very nice. Looks like you've got Prevnev's hands up. You have to unmute yourself there.
Get a little lighter.
Yeah, hi, Bob. So I was just throwing out one idea that 3D printing for buildings might help push the cost curve down even further, but I know it's still emerging, so that could be a little while. But I was curious, so are larger cities not sort of your prime target at this stage with the volume of people in that area? I guess you need a sponsor essentially for the facility cost up
Yeah,
front.
I'm not, first of all, the 3D printing option for manufacturing is a fascinating one. My partner, Greg, is the architect and engineer. I'm not that guy. I'm kind of the guy trying to drive the healthcare piece of this component. He's really driving the building. I don't know if he's explored that, but I will ask him about it because I think it's actually a great idea. So thank you for that. And then I'm sorry, I forgot the second question.
Oh, yeah, I guess larger cities in terms of the addressable market. And
we're not opposed to doing it anywhere that it makes sense. So if you have a large community that's really getting taken to the cleaners by the healthcare systems and the carriers, we're happy to do it. The name of my firm is Disruptive Strategies for a reason. I don't mind poking the bear a little bit. I don't mind pushing the envelope with the carriers and with the systems. I think we can partner together better than we can be adversaries, but they need to be pushed along too. They will not change what they're doing. I can promise you that, unless they're forced to. So anywhere.
Are there some states where, in terms of regulatory barriers, you could not do this? Or could you, if you could do it anywhere, maybe pick the states where insurance costs are the least competitive and target those?
Yeah, that's a fantastic marketing strategy. I haven't looked at any states that I would think would be a problem. If you have self-funded employers, it's a pretty broad canvas of things you can and can't do. You're the fiduciary for your plan and for your employees and their families, so you need to do what's best for them. It's pretty tough to tell a fiduciary they can't do something that's beneficial to their members and to their plan.
Thank you.
Dr. Campbell?
Yeah, I wonder, Bob, if you've ever had trouble with the big guys, any issues of ERISA compliance? Do you have to get a waiver, or do they try to beat you up with that?
No, we haven't run into that yet. It's interesting because if you think about it, there's various layers of this, right? They can push hard on us, and they do typically, when they hear we're coming to town. I spent some time in the on-site, near-site clinic business before. Anytime you come to a community, the healthcare systems are going to push back, right? And they're going to push as hard as they can until they realize you're coming anyway. And then they want to be your absolute best friend because they realize they're losing the golden goose. And the golden goose is the primary care. So when they lose that, they lose the $2 to $3 million in revenue that comes from each one of those physicians, right? So they need a way to replace that. And so they'll push real hard until they realize they can't keep you from coming, and then they will want to work with you to try to make sure they don't lose all their revenue.
Well, that's good. It's nice that you can kind of divide and conquer them that way, because it's hard to displace somebody. If you find a place for them, then they're content to coexist. But for sure, like any change, they want to resist and maintain their spot as long as they can. But after a little bit, like you said, it starts to become a multiplier effect, because once people see this is working, and for the one that you've had on for the longest, what's the level of receptivity on the employees? Do they really like this new change for themselves, other than just maybe being cheaper?
They're in a temporary clinic space right now, and they love it. So the provider's doing a really good job. It happened to be a local on-site, near-site clinic provider who was awarded that business. We did the RFP with one of the brokers of the four of them, I was an independent voice on that process to try to help make sure that it was open and fair to everybody, so that the other three brokers weren't concerned that the one broker was trying to drive the train. Right? I actually have more difficulty in many cases with the brokers and consultants who think I'm trying to get in their kitchen when nothing could be farther from the truth. I'm actually just trying to help give them some tools to help them.
So it's nice to hear a clinic where like it's a win-win. I'm in a city that shall not be named, and whenever you go to this monolith, you don't feel like you're getting the best end of the bargain. So you're not leaving as a happy camper. They are. So this is great for sure. Well, we're reaching the end of our rope here a little bit there, Bob. So I really appreciate you spending some great time with us and bringing us up to speed on this really very exciting and very helpful endeavor you've got going here.
Yeah, thank you guys, and thank everybody for your attendance and your attention and your questions. Thank you very much.